This is Professor Michael Chapman. I'm one of the most experienced IVF doctors in Australia. I believe that an important part that I can contribute is to educate patients in relation to fertility, infertility, and all that involves. These series of podcasts help to educate you. I hope they are helpful to you. If you wish to know more, however, I'm more than happy to have you contact me via email, which is profmchapman@gmail.com, or make an appointment to see me on 9138 4222.
Prof Saleh is here. She says, I hope I'm on time. She is. She says, I want to start my journey. I need some advice. What tests should I do before starting my journey, please?
Well, if I go back one step, before you do the steps, tests, find a fertility specialist who knows what they're doing, because they'll organise all those tests. And really, you can go to your GP and ask them to do a pilot test, but then they've got to be interpreted. It's probably better to go straight to the fertility specialist if you're having trouble getting pregnant. Yeah, I talk to patients all around Australia, and in fact all around the world, because of this Facebook Live program by Zoom, and I'm more than happy to talk to people and get them on the road in regards to starting the journey.
So, Prof, how do you interpret Mosaic embryo results in real-world practice, and how do you guide patients through the uncertainty of transferring one?
Yeah. Yes, so let's talk about what a mosaic embryo is. So when we genetically test embryos, we're taking around about 10 cells from the 400 that are present in a day 5 embryo and sending them off to the laboratory. For an embryo which is really abnormal, all of those cells potentially will be genetically abnormal and have either more chromosomes or less chromosomes than they should have. So that's an aneuploid embryo. The alternative is that all the 10 cells that we measure are actually normal. 46 chromosomes, fantastic. Yes, that's a euploid embryo. However, because we're testing 10 cells, it's not that uncommon to have 1 or 2 cells out of 10 that are genetically abnormal when the rest are normal. There's a cutoff point that the scientists have that say, well, we'll call this one normal because it's actually only got 1 abnormal cell. Once they've got 3 or more cells out of the 10, but they don't have 8 out of the 10, we call it a mosaic. So it's halfway between. And we can't tell from that whether this is going to be a normal embryo or not. Part of the problem in it all is that what we're testing are the cells on the outside of the embryo. We're not actually testing the actual baby itself. So it's still a distance away. And we also know that a significant percentage, like more than 50%, of placentas in normal children when they're born actually have mosaic cells amongst them. So it's actually quite common in nature to have mosaicism. So the question is, if we find that mosaic embryo, the laboratory tells us it's mosaic, what should we do? This has been a quandary for the last decade, because that's when we first started to find these in-between normalities. However, what we know is that over the 35, 40 years of IVF, until genetic testing came along, we were putting back embryos that almost certainly a high percentage or a significant percentage of them were mosaics. And guess what? We didn't actually have any increase in baby abnormalities. So even though we must have been putting back mosaic embryos because we didn't test them, we didn't end up with abnormal babies. The fully abnormal aneuploids get rid of themselves, either through not implanting or miscarrying during the early stages of pregnancy. So nature actually determines that outcome. For the mosaic embryo, almost certainly, if it really was reflecting actually an aneuploid embryo, then nature will deal with it again the same sort of way. It'll be lost. If, however, is actually a normal embryo, it will go on like a normal embryo. And so I personally, when I counsel patients, tell them that a mosaic is actually the equivalent of an untested embryo. And we've been putting those in for 40 years. And now we have data showing that the pregnancy rate for a mosaic embryo is exactly the same as an untested embryo. So the miscarriage rate is the same, the abnormality rate is the same as if we had never tested the embryo. So I don't find any problem in putting back a mosaic embryo. I suppose there are a couple of exceptions to that, and that's if the mosaicism happened to include a Down syndrome type mosaic. If some of the cells had trisomy 21, there's another couple of other ones where pregnancy may well go on, but before it will go on despite having an aneuploid embryo. And so there are 2 or 3 mosaics where I would say, it's probably not a good idea to put back. But the remainder, fine. People go to the extent of having genetic counselling, talking to geneticists, but they end up with that same advice. The odds are this will be fine. And we've been putting back mosaic embryos now for a decade, and there is no increase in baby abnormality rates compared with the background IVF rates. So I think up to a point, I see it as a bit of a storm in a teacup of science being too clever for itself.
In which clinical scenarios do you still favor fresh cycles, and when are frozen cycles clearly superior?
Well, a frozen cycle I don't think is ever superior unless you're using that frozen cycle to genetically test embryos. The overall statistics suggest that a fresh and a frozen are the same in terms of pregnancy rates. I mean, the advantage of a fresh cycle is to putting back fresh is the woman knows she's going to be pregnant that month or not. But other than that, there's not really any advantage. And there are patients where, and it perhaps is the data in relation to fresh cycles is now becoming biased. Because we do so many freeze-alls, then the other reason for doing a fresh transfer is, sorry, I've got some background noise. Hold on. The reason for doing a fresh cycle might be that we grow the embryo to day 3 or 4 and it doesn't look so good. And let's put it back fresh because maybe in the uterus it'll do better than in the lab. But of course, they are the bad embryos and they will reduce the overall success rate of fresh transfers. And I think we're starting to see that in the Australian data, that fresh transfers don't look so good, but it's because they're a biased population.
And don't forget that you can access all the previous episodes by going to our website www.theivfjourney.com and select IVF Journey podcast from the navigation menu.